Hello, everyone, and welcome to the PBRN webinar on contemporary issues and economic assessments of interventions in primary care. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Rebecca Roper, Director of the AHRQ PBRN Initiative, will introduce today's presenters. We will then hear from our presenters about their work conducting economic assessments. We will have a brief question and answer session after each presentation, and we will also have time for a final question and answer session with the full panel. At the end of the webinar, I will explain how to obtain CME credit for participation in this webinar. Please note that after today's webinar, a copy of the presentation slides will be emailed to all webinar participants. I'll now explain how to submit a question to today's presenters. To submit a question, you may use the GoToWebinar control panel. Type a question under the Questions section and hit Send, as shown in the screenshot on this slide. You may submit a question at any time throughout the presentation. During the Q&A sessions, as time allows, your questions will be read out loud and our presenters will respond. I'll now turn the presentation over to Rebecca Roper to introduce today's presenters.
Good afternoon. I'm so glad that you all could join us. One thing I wanted to ask folks on the call, both the presenters and those who are poised to ask informative questions, is to also send in to us suggestion of good references. We had a webinar last month where folks online also provided to us some other references that helped us build a nice compendium of additional references. So I'll reinforce this at the end, but the PBRN email, pbrn@aptasssoc.com. If a good reference or website comes to mind as we listen to these presenters that you would like to make your community aware of those other references, send it to us and we'll include it in a compendium, an informal compendium of possible references on this topic. So we have three sets of presenters today, and I'll introduce each of the three in turn. Our first set of presentations will be by Dr. Elbert Huang, as the Associate Professor of Medicine, Director of the Center for Translational Policy Research of Chronic Disease, and Associate Director of the Chicago Center for Diabetes Translation Research at the University of Chicago. He has also served as advisor in the Office of Assistant Secretary for Planning and Evaluation, which for those people who spend more time in downtown Washington know that as ASPE, as the Department of Health and Human Services. And just as a point of information, AHRQ's leader, Dr. Kronik, he was in ASPE as well. Dr. Huang is a general internist who studies clinical and healthcare policy issues at the intersection of diabetes, aging, and health economics. His main research focus is in the area of medical decision-making for the elderly patients with type 2 diabetes, in which uncertainty exists regarding how to best individualize diabetes treatments based on clinical parameters and patient references. He and his co-presenter, Dr. Robert Nocon, who has a research focus on cost and organization of care in safety net settings. Robert's current projects include evaluation of a patient-centered medical home implementation in safety net clinics, and analysis of cost of care provided in federally funded centers using Medicaid claims data, and a cost assessment of a community-based quality improvement collaborative on the south side of Chicago. So we welcome these gentlemen from Chicago. They'll give about a 15-minute presentation. Then you can send your questions, and we will respond in turn. One thing, as folks begin to think about questions, and we will have a collective question and answer across the three presenters, it helps if you identify which particular project so we can target the correct person to answer. We can always open it up if it's a general methods question to all of our presenters at the end, but if you have someone's particular expertise you seek, it helps to clue us in from whom you wish to hear. So with that, I will turn it over to our wonderful people in Chicago. Thank you.
Thank you very much for that kind and generous introduction. Can everyone see the slides?
They look great.
Wonderful. So the goals for today are just to describe 3 approaches for economic assessment of primary care interventions. We'll highlight key questions and challenges for you to consider in your own work in improving care in primary care settings, and show some brief snapshots of examples from our work of how we apply these different methods. So it goes without saying that this quote basically reflects that the general problem, which is that we have to control healthcare costs. And as Dr. Emanuel said, it's controlling healthcare costs is a fundamental domestic policy challenge facing the United States. Physicians and all providers must commit themselves to act like the captain of the healthcare ship and take responsibility. And this is really the motivation behind a lot of this research around how much it costs to improve care in primary care settings. So we have our work is based on experiences in different intervention settings. So we are actively involved in a Commonwealth-funded project called the Safety Net Medical Home Initiative, which is being done in 65 clinics in 5 states. It's basically a PCMH intervention over 4 years, and we are the evaluation team for that project, and we'll talk about some of our early findings from that study. We are also going to tell you a little bit about research that we've done on the south side of Chicago, where we've done a health economic evaluation of a diabetes improvement initiative in 6 clinics, again in the south side of Chicago. It's ongoing since 2009 with an emphasis on community engagement, patient-provider education on shared decision-making. And our experience is rounded out by our long-term experience working in federally qualified health centers. We were the evaluators for the Health Disparities Collaborative, which was started in the late 1990s and took place nationally in HRSA's federally qualified health centers. And we'll talk about our experiences in economic evaluations from those studies. So we think of 3 types of cost questions for primary care interventions, and they're pretty basic. One is, how much does an intervention cost? What resources were used in planning and conducting the intervention? And we feel that these sort of cost studies are not done enough and could inform actually a number of different policies from incentives to penalty design. Second, what are the costs of patient care that are the result of any primary care intervention? In other words, what happens to the cost of taking care of people once an intervention is implemented? And the third cost question that we think a lot about, that actually Sheila Leatherman called the business case for improving care, which is what happens to the finances of an organization when they take on a primary care intervention. This is, again, probably underappreciated, but well known to primary care facilities that are trying to improve care. So first, our first question: what is the cost of an intervention, and how do we estimate this for a given intervention? So the challenge in quantifying the cost of an intervention is that that sometimes the interventions are complex, and they take place in complex settings where there are multiple factors going on at the same time. Sometimes practices are changing multiple things, and so it's hard to disentangle the actual pure cost of intervention. Costs may also change for a given intervention over time, and that has to be factored in. It takes sometimes time to start a project, so there's the run-in costs, there's stops and starts to interventions that one has to account for. One challenge in many clinical settings is that the personnel involved in intervention turn over a great deal, and so there has to be someone there to see that and to account for those changes. We think that the clinical and overall health economic context of the intervention is important to know about. Are there new contracts that a clinic has signed on to? Are there big changes in the way that the clinic operates? Those all require some attention when thinking about the cost of an intervention. It's sometimes not as easy to see. So here's some tips for assessing intervention costs. Don't try to take on the beast all at one time. Break down the complexity. Ask about individual parts of the projects. Collect data as frequently as is reasonable. A second major tip is to count the effort of individuals, even if this includes missteps in improving care. So we all know that in quality improvement we do PDSA cycles. Well, all those PDSA cycles count towards the cost of an intervention and need to be counted. And as long as you count effort, you can always transform that effort into a dollar value. And finally, you have to understand the context of the intervention. Are there other contaminating related efforts, and how have they affected the primary intervention? A lot of that understanding can be brought about by conducting qualitative interviews and discussing the non-financial costs and benefits of an intervention. We have found that oftentimes facilities are still interested in carrying out interventions that are expensive because they see value beyond dollars. So some snapshots of example data collection tools that we've used. We have created intervention activity surveys that help us outline the major components of intervention and break out staffing time and purchases. And these are done annually as part of our evaluations. We've also in the past developed qualitative interview guides that we use, again, where we talk to leaders of the intervention and major providers and staff about what they perceive as the costs and benefits of the intervention. So these are snapshots of our intervention activity survey where we've asked, for example, this survey comes from our Southside Diabetes Collaborative, where we've asked people about specific activities that we knew about, collaborative meetings, quality improvement team meetings, the formation of diabetes group visits, and so on. And this is more detail from the intervention activity survey for a particular site that was using wallet medication cards as part of their intervention, and so we had to figure out the cost of those wallet cards. So this is an example of the kind of question that we would ask in qualitative interviews with leaders of the intervention. You know, has the project affected the clinic's reputation in the community? Do you think the project has attracted new patients? Are there negative or positive impacts on provider productivity, and what parts of the project are most costly? So this sort of combined quantitative and qualitative method we used originally in the Health Disparities Collaborative interventions, where we literally got into a van and drove around the Midwest visiting several selected case sites and basically downloaded both qualitative and quantitative information to try to figure out the impact, the cost consequences of improving diabetes care as part of the Health Disparities Collaborative. And we found that there was high variation in the cost of the intervention from one site to another, and that there were non-financial costs and benefits that carried heavy weight with clinical leaders that were doing the intervention. So I will pass this on to Robert Nocon now.
Thanks, Elbert. So as Elbert mentioned, we wanted to cover give you a snapshot of three types of economic questions that we ask of primary care interventions. And we spent most of the time on the first one. We think that's where the work is most directly relevant to your work in primary care clinics. And it's also where the data is most readily available. There's sort of things happening sort of in your house as a primary care provider. The latter two research questions we just want to provide a snapshot of. They tend to reach into areas where other folks own the data, and they can sometimes be more challenging to get to. But again, we just wanted to quickly highlight the types of questions you can ask. What are some of the challenges and tips for approaching those questions? So one of the most obvious questions that Elbert mentioned is sort of how has the cost of patient care changed as a result of the intervention? And for primary care interventions, there are several important challenges that make answering that very simple question very hard for us. So first is that patient care costs are distributed across organizations, and you folks know this well. Oftentimes, in fact, most of the time, the vast majority of costs occur at places other than in your primary care delivery site. So specialist costs, and hospital costs. Secondly, related to that is that investments in primary care often have benefits in those downstream utilization outcomes. And third, also related, is that some of the most costly types of patient care that you're trying to capture, they can be rare among a general primary care population. So those are all challenges that make sort of you, presumably from your position seated in sort of a primary care organization, that make it more challenging to assess overall the cost of patient care. You know, and there isn't really sort of a magic bullet to point to with respect to dealing with this problem, but we thought we would highlight sort of a couple of sort of common sources of data and tips to consider if you choose to pursue this type of research question. So first is that while data from an integrated provider network, a provider that covers sort of all types of care, inpatient, outpatient, from emergency department, et cetera, that may be ideal. Those folks have often sort of massaged and worked with the data across settings and can easily sort of relate operational changes in the clinic to sort of how that manifests itself in terms of raw data. But that's hard to find. There's not still today aren't many sort of places with integrated data in that way. So another common place that folks look is to claims data. And so data from a common payer can cover a large portion of patients in an intervention. So if you're in a clinic that is primarily delivering care to Medicare patients or Medicaid patients, or even to a single large insurer or single insurer, you can get data that captures a large portion of your intervention patients. And I'll show you a sample of an analysis that we did that used payer data. One of the challenges here is as you get sort of more into a claims database that sort of lives at a payer and further away from your primary care delivery site, you lose detail. You lose some of the ability to connect what's happening in your intervention with what you see in claims. So, for example, we do, as Elbert mentioned in our medical home analyses, we look at Medicaid claims data for clinics becoming a patient-centered medical home. And one of the challenges with that is that people identify the provider in Medicaid claims data very differently. Not everyone uses the individual physician NPI for everything. There's a complex sort of process to finding your patients in that big mix of data from a health insurer. Another point, so I mentioned that many of the most costly cost outcomes are rare for a general population of primary care patients. So another common strategy is to consider focusing your analysis on subgroups that have the most likely high cost outcomes. So we frequently focus our analyses on diabetes patients, for example. And lastly, when dealing with these types of claims data questions about cost of patient care, you really have to pay special attention to the scope and limits of your data source. So if you have payer data, ensuring that there isn't a great deal of out-of-network utilization, that there isn't a lot you don't know about happening outside of your claims. And then there's just the delay and challenges of doing those types of claims analysis. A lot of times you need several years to pass before you're confident about the cost data that's in claims. That happens, for example, in Medicaid claims. One example piece of work where we sort of were able to get through a lot of the challenges with respect to these claims analyses is a paper we published earlier this year in Health Affairs about a text messaging primary care intervention that we did here at the University of Chicago. We used health plan data that we had our single employer health plan that covered all of the people who we had in the intervention. It was targeted towards health system employees. And here, towards that point of out-of-network utilization, that health plan captured 90% of utilization. Their out-of-network utilization is only about 10%. So we felt really confident that we sort of knew what was going on with the healthcare activity for these patients. And we saw that there was a net cost savings in that project of 8.8%. So there was a cost of delivering the intervention, but that was outweighed by, and actually there was cost of delivering the intervention, increased cost of drugs, but that was outweighed by savings in emergency department visits, inpatient visits, and outpatient visits. I'll quickly touch upon the third type of question, which is thinking about the organization as the unit of study. And so here we would ask, how has the organization's financial performance changed as a result of doing the intervention? And the biggest challenge here is first really ensuring that you have a good conceptual link between the intervention and organization finances. So we had taken on this type of research question in past studies of some of our diabetes care interventions. And what we realized is that sometimes the intervention must be large enough to have an impact on the organization finances. Sometimes as much as we thought that the intervention that we were evaluating was a big deal, in the broad scope of the organization and how they make money, it really wasn't. And so we collected data, yet weren't able to sort of see a signal in terms of there being an effect on organizational finances. Also, there's lots of complexities in terms of how organizations are paid. So you have to have that conceptual link really clear between what you're doing in the intervention and how that would potentially make or lose money for the organization. And lastly, it's difficult to find standardized data sources across multiple organizations. Folks obviously hold tight to financial data. So unless you have good access or using a standardized data set, that can be tough to answer. It can be tough to get to these questions. The example piece of work that we've done here, where we really were lucky enough to find a setting where it was sort of a large intervention. It was a patient-centered medical. We're looking at patient-centered medical home performance, and we used a standardized data set insofar as HRSA, the agency that funds health centers, collects a national standardized data set. We looked at whether higher rating as a medical home is associated with higher operating costs, and found that indeed a 10-point higher PCMH score on that 0 to 100 scale that we used was associated with a 5% higher operating cost. And while that might not seem to be a lot in a lot of businesses, that's higher than the average health center margin. And so it's sort of really significant and meaningful sort of dollar amount to sort of the financial survival of the organization. So those are sort of three types of cost-related research questions. We thought we would provide sort of a higher-level overview. And I think in seeing some of the other presentations that are upcoming, some of those also dive more deeply into looking at specific methods and data tools. But we thought that an overview might be helpful to folks. So I think we can open it up for questions.
Sure, if you just type in your questions, and while we wait for a few people to pose a couple of questions. So you had three basic research areas, and you discussed a little bit about the challenges of getting data for in the cost of intervention, cost of patient care, and the organizational financial issues. With respect to value beyond dollars, and that's a well-stated finding, do you propose any indirect cost estimates that would eventually get at the value to the organization for the different interventions that could really more fully characterize the cost of the intervention and the cost of patient care?
Yeah, I mean, I think first in terms of what we've done, we've tended to try to capture that as much as possible, as Elbert mentioned, in qualitative interviews. Though, going further and trying to quantify things like, I assume you're talking about sort of quantifying the consequences of things like morale or burnout and turnover,
right?
And insofar as those can manifest themselves in terms of like days worked and such. We haven't taken that step in analyses to date, but I think that would be sort of the next step and sort of a promising area to look into, to really sort of to go beyond describing it and quantifying it.
And I would add further that we actually, in other work, sort of have come to the conclusion that provider or staff satisfaction is actually something that we should do routinely in almost all interventions or all new financial schemes, because it's really important for the overall health of the business of these organizations.
Okay, thank you. I'm going to articulate to you a question that's rather detailed, and at the open discussion at the end of the other presentations, we'll come back to you for the answer. But this is a very detailed question. Is there a data set that you would recommend to analyze the impact of a particular diabetes-related intervention on patient costs to demonstrate a return on investment? So we'll squirrel that away for now, and we'll go back to you on that if you don't mind. And thank you for the questions, and we'll move on to our second set of presenters in Palo Alto. So we'll move west. So we will be joined by Dr. Ming Tai-Seale, who is a senior investigator in the Palo Alto Medical Foundation's Research Institute. Her research focuses on the effect of financial and organizational incentives on practice behavior of healthcare providers and the subsequent impact on cost, utilization, and quality of healthcare. And 2, the economics of healthcare disparities and the economics of mental health services in primary care. Dr. Tai-Seale has contributed to the understanding of time allocation decision-making and patient engagement in biomedical and mental health care and primary care practices. And she will be joined by Dr. Cheryl Stults, who is a research sociologist also at Palo Alto Medical Foundation Research Institute. Her research focuses on patient-provider communication and the evaluation of primary care redesign initiatives, particularly in shared medical appointments. She is co-investigator for a study funded by the Patient-Centered Outcomes Research Institute, otherwise known as by you all as PCORI, to help create a more patient-centered tool to assist Medicare beneficiaries in selecting a Medicare Part D prescription drug plan. She is currently working on several studies, including how to create a zone of openness for patients to foster more open communication with their primary care providers, and an activity-based costing of primary care transformations, including shared medical appointments. Welcome, Dr. Tai-Seale and Dr. Stults.
Thank you. Oh, great. Let's see. All right, here we are. So I will just say a few brief words about the context of this study, and then Cheryl will do the heavy lifting of presenting a part of our study. So we were fortunate to have had a grant from AHRQ to study the transformation of primary care at the Palo Alto Medical Foundation. That was a few years ago, and during that work we learned a great deal about various components of primary care transformation that's been happening in the delivery organization, and one of which is shared medical appointments. So the Palo Alto Medical Foundation is kind of in the leading edge of providing shared medical appointments. So we were again fortunate to apply for funding and receive the funding from AHRQ to do a follow-up study that particularly look at the costs of transforming primary care. So one of the things we propose to do is to look at the cost of supporting in terms of designing and implementing shared medical appointments. So with that being said, I will turn this over to Cheryl, who will share what we have learned so far. Thank you, Dr. Tai-Seale. So the title of our talk today is Estimating the Cost of Supporting Primary Care Transformations, the Case of Shared Medical Appointments. So I'd also like to thank Dr. Sean McClellan and Dr. Laura Panettone, who are our co-collaborators on the study, as well as AHRQ for providing the funding, and also the Richard and Susan Levy Family Foundation. So the Affordable Care Act has recently begun to give coverage for uninsured and underinsured Americans, but will not solve the existing primary care access problem, and lack of access will only intensify with an estimated 32 million individuals becoming insured by 2019. Additional strain on primary care is also expected, given the aging baby boomers becoming Medicare eligible, as well as older patients requiring more healthcare resources and having more chronic diseases like diabetes, hypertension, and heart disease. So one possible solution that is a component of the patient-centered medical home is shared medical appointments. So shared medical appointments, SMAs, or group visits, are medical visits where multiple patients are simultaneously seen by a physician in a group setting. So this is an example of an SMA that is conducted in one of the clinics. So shared medical appointments help access to care in a climate of primary care shortage. SMAs can also increase practice productivity and provider satisfaction. But the benefits of SMAs extend beyond just improving clinic efficiency. SMAs also have numerous important benefits for patients, including overall satisfaction and improved clinical outcomes, including weight loss, hemoglobin A1C, and blood pressure control. The barriers exist to SMA implementation, including overall financial and administrative hurdles, adequate staffing for SMAs, adequate facilities and resources, as well as some non-financial barriers of a lack of motivation from providers to utilize the new method of care delivery, as well as patient expectations of what a doctor visit should entail. So this leads us to our research questions. What is the human resource cost of developing and implementing a program to support SMAs? And then once that program is established, what is the human resource cost of adding a new SMA, specifically one on cancer survivorship? So I want to preface our results with a quote from the SMA coordinator that she made about implementing the SMA program that is also applicable to our analysis of the cost. She says, quote, "Because with SMAs, it looks very simple from the top view at 40,000 feet. But when you drill down at ground level, there are a lot of variations. There's a lot of things to consider, and there's a lot of moving parts." So we utilize an activity-based costing approach to provide greater visibility into the organizational process and their cost compared to standard accounting. So this methodology is well suited to accounting for human resource costs, which tend to dominate new product development. Human resource costs will be analyzed according to what tasks or activities were completed, which personnel were involved in each activity, and how much time was spent on each activity. All development and implementation human resource costs were included. Other costs, such as materials, podiums, computers, and copiers, or room use, were excluded from this presentation, but we are studying that and further analyzing it. Other costs, so to maximize generalizability, costs were calculated as time spent on each activity by each employee multiplied by the 2013 Bureau of Labor Statistics national median wage. So our study takes place in a large nonprofit multi-specialty group practice in Northern California, which serves 4 counties and more than 700,000 patients. So our primary source of information came from in-depth key informant interviews with stakeholders from different levels of the organization. So our presentation today focuses on the implementation of a SMA program at one clinic. So here is the timeline of the implementation process for the SMA program. One physician at the clinic, whom we term the physician champion, independently saw the value of SMAs and began to practice them on his own for 10 years. In December 2009, the clinic decided that they wanted to institute a SMA program, so they hired the SMA program coordinator. She worked on her own for 7 months researching and learning about SMAs before she learned that the physician champion had already been doing SMAs. In July 2010, the two of them teamed up, and with the assistance of a medical assistant scribe and the operations lead,
the Clinic SMA program was born. So this team of 4 continued working together and growing the SMA program. They were so successful that in May 2012, they were given more money to expand their staff by adding a department coordinator, 1 more MA scribe, and 3 patient service representatives responsible for scheduling and checking in patients. This staff of 9 composes the program as it exists currently. So we decided to focus on the area of the timeline enclosed in the box of January to June 2010, and then July 2010 to April 2012, as the program, that is the period where the program was being established. If you note off to the right, we have a little box and it says the Cancer Survivorship Shared Medical Appointment. So the Cancer Shared Medical Appointment came after the expansion of the program, and that occurred from October 2013 to February 2014. So this slide explains the tasks completed by each employee involved in developing and implementing a SMA program. I am going to illustrate only the SMA coordinator, who is featured in the yellow box, as she spent the most time and had the greatest cost for the project. The activity that took the most time was development of and research for the SMA program at 1,211 hours. So here's a little bit more explanation of this specific activity she completed in her own words. Quote, so I did a lot of research. I looked around and tried to see what a lot of other organizations were doing. And there's a group back east. They were running 90 SMAs a month. They were just huge, gigantic. They're one of the largest healthcare providers out in Boston and New York area. And she, SMA leader, program lead, was very willing to help me. She also said that, quote, I spent quite a few months laying out on big postboard different workflow scenarios and how we could do this or how I could do this. And I just kind of built it. So for developing and implementing a shared medical appointment program, the SMA coordinator spent the most time of 1,255 hours, which at the national median hourly wage, according to the 2013 Bureau of Labor Statistics, is $44. So for a cost of $54,869. So the specific activity that took the most time was development of and research for the SMA program at 1,211 hours at a cost of $52,945. So the overall human resource cost in terms of time was 1,360 hours and a total cost of $62,874. So once the shared medical appointment program was established and had been running for a few years, what was the total human resource cost of developing and implementing one new topic as the shared medical appointment, specifically on cancer survivorship? So most of this, the development and implementation for this one shared medical appointment occurred from October 2013 to February 2014. I am highlighting this time on the physician who is featured in the green box since she had the most time and costs. The activity the physician spent the most time doing was researching and developing the material for the shared medical appointment at 40 hours. Half of that time was spent constructing a PowerPoint presentation, ensuring that all the facts were correct and referenced. As she states, quote, I tried to always do about 3 sources, just sort of get a consensus, put that down, and then reference them at the end. So different journals, I tended to use medical journal articles, things like that, and then big cancer centers, UCSF, MD Anderson, UCLA. So the physician spent the most time, 72.5 hours, and had the highest cost of $6,513 in developing and implementing a cancer survivorship SMA. Research and development of material for the shared medical appointment took the most time overall, 44 hours, for an overall human resource total employee cost of 91 hours and $7,271. So the first 4 bullet points apply to implementing the shared medical appointment program. The physician champion spent several years, 10 years, conducting shared medical appointments before beginning the program, so he had great experiential knowledge before starting. We estimate that the human resource cost to develop and implement a program to support shared medical appointments was $62,874. The shared medical appointment coordinator spent the most time and cost the most. The most time-consuming activity was development of and research for the Shared Medical Appointment Program, 1,211 hours, $52,945, and which was completed by mostly by the Shared Medical Appointment Coordinator. So the final 3 points apply to the one topic, Shared Medical Appointment of cancer survivorship. So we estimate that the cancer survivorship Shared Medical Appointment human resource cost was $7,271 to develop and implement. The physician spent the most time and cost the most, then followed by the Shared Medical Appointment Coordinator. The most time-consuming and costly activity was the development of the materials, which was primarily completed by the physician. So the limitations of our study, it's largely occurred in a fee-for-service organization, so it's not applicable to all primary care practices. Only one case of one clinic and one topic SMA we're focused on today. So in order to better understand cost, we need to look at another group. We're continuing to further our work on the grant by looking at another recently implemented Shared Medical Appointment topic within the clinic that we illustrated today, as well as we are looking at the cost of establishing another Shared Medical Appointment program in a different clinic. Our estimates are based on individual self-reports, and given that participants were asked to recall things about actions that happened years ago, there's a potential for recall bias. But due to this, we feel that the results are probably an underestimate of the amount of time actually required. So the implications of our research: developing and implementing a program to support shared medical appointments required significant time of the Shared Medical Appointment Coordinator. Introducing new physicians or a new type of SMA may require a relatively modest commitment of organizational resources, and it's possible that the total time and cost could be decreased by utilizing existing materials from previous established topic SMAs. So just to reiterate, and going back to our initial research questions, what is the human resource cost of developing and implementing a program to support shared medical appointments? And our second question was, once established, what is the human resource cost of adding a new shared medical appointment specifically on cancer survivorship? For initiating a program, the total employee time was 1,360 hours, and the total cost of $62,874. And for a one-topic SMA, it was total employee time was 91 hours, and a total cost of $7,271. Thank you.
So thank you very much. With respect to the SMA coordinator and the physician champion, maybe I misunderstood, but the physician champion had 10 years of experience using an SMA, and you had a new coordinator who conducted research for about a 6-month interval, and then there was, as I understood it, a synergism of the two being at the same location, and the SMA went into place. Was there some lost opportunity on getting some of the primary research done by the SMA coordinator because they hadn't connected with the physician champion, or did I just misunderstand the sequence of events?
No, you are correct in that, and the two were really working kind of in parallel. And so the one had been doing it for 10 years, but he had not really made it known to the rest of the clinic. So when the clinic decided to bring in the coordinator, she did not know anyone else was doing it. So then after 7 months of doing it, researching on her own, then she found out about the physician champion, and then together they teamed up. So okay. No, you're correct in that.
Okay, and so you had, which happens, it happens right here in the federal government that we were acting in isolation. What type of strategies would you pursue to leverage other activities for SMA coordinators, both internally with your organization and elsewhere, having gone through this experience that you hadn't thought of before?
So I would say in terms of leveraging the internal and external resources, so something that we are doing now is we found out that someone is going to be starting a shared medical appointment. And so we've asked her to keep track of the amount of time that she's doing, specifically like logging the hours. So in that way, we'll be able to lessen some of the recall bias that's from there. And then in terms of externally, I would just say that it's kind of our previous presenters mentioned, it's really important to get the context for the overall clinic and setting, and so really understanding the history of the organization and the history of the program will help in better understanding.
Okay, if I can ask a few more detailed questions, and then we'll go on to our third presenter and have open-ended. So a few of the folks have posed some great questions. How can SMA be identified in a claim code specific in primary care physician offices or for specialist reimbursements? Do you have some suggestions on that?
Oh, sure. Do you want me to give it a
Yes,
stab?
go ahead, Ming. Yep.
Oh, okay. So some of these visits, the clinicians would code a group visit CPT code, and they would often also include the 99213 code, because as you may notice in the diagram of the SMA spatial arrange, sort of the spatial map, physicians will oftentimes spend some time with each individual patient where the other patients are listening, so that there could be sort of cross-pollination, could happen, but the physician is paying attention to the particular individual patient. So there's still a assessment and management component for the individual patient as well as the group visit delivery. So now that more and more people are aware of the clinicians who are doing the SMAs in the organization, there is some effort afoot in trying to standardize the way the codings are done. Does it answer your question?
It answered the question. I will tell you we have a few more questions posed, and if we can keep you on the line, we will be asking a few more questions after our third presenter. Would that be all right?
Of course.
Yes. Okay, great. All right, so we have our third presenter from Colleen Payton, who is a clinical research specialist in the Department of Family and Community Medicine at Thomas Jefferson University. She is currently a doctoral student at Jefferson School of Population and Health, with 3 chairs that she continues on with this great work. And Colleen received her master's in public health from Thomas Jefferson University. Her research interests include women's preventive health, chronic care management in refugee population, and population health curriculum. And she represents a very strong team from Thomas Jefferson, and we're glad she's able to join us today. Colleen?
Hi, good afternoon, everyone.
Colleen, it's hard for us to hear you. If you could just speak closer.
Can you hear me okay now?
Much better, thank you.
Okay, great. Hi, everyone. Good afternoon. I'm happy to be here today talking about a study exploring the cost of the patient-centered medical home in small primary care practices. And as we've discussed this afternoon, the patient-centered medical home is really a key vehicle for healthcare delivery system reform, whose value proposition is really still in its early stages. There's little information as how much it really costs to implement this model of care from the practice's point of view. And before I start today, I just wanted to acknowledge the cost study research team that I was part of. Our PI is Dr. George Falco. And I also wanted to note that this project was supported by an R03 grant funded by the Agency for Healthcare Research and Quality. So my objectives for today are to outline our project's approach to estimating the financial burden of the patient-centered medical home for small primary care practices specifically, and then to describe the cost collection tool we created for both transforming and sustaining the PCMH model. There's no singular definition for the patient-centered medical home, but it can be viewed as an approach or model that helps primary care shift from episodic care to a more proactive population health approach to managing care. And as I mentioned earlier, there's a growing literature suggesting that the patient-centered medical home improves the quality of care delivered to patients as compared to other practices. But there's little to no literature on how much it costs from the practice perspective to implement this patient-centered medical home model. It has been suggested that the success of the patient-centered medical home model may rest on its uptake by small practices across the United States. And this remains a concern as many of the costs associated with transformation to PCMH are large, upfront, and fixed costs. So small practices in particular may not have the financial resources, the capital, or staff members readily accessible to purchase an EMR, hire additional staff, or complete time-intensive activities. So it remains an open question whether the PCMH model can be adopted by small primary care practices. Since we were asking a question that really hasn't been answered before, we really were hoping to take both a comprehensive and pragmatic approach to answering this question of cost. So we first administered a survey adapted from the NCQA 2011 accreditation guidelines to 11 small patient-centered medical homes in southeastern Pennsylvania. And then we conducted semi-structured interviews to identify the clinical activities associated with each element of transformation. From that, we created a taxonomy of costs reflecting clinical activities and insights from the PCMH implementation process. And then finally, after gathering and analyzing this data, we then drafted a cost collection tool that will help practices really quantify all of their costs towards practice transformations. So even within small primary care practices, there were a lot of differences. Just first to note, 5 out of the 11 practices are level 3 NCQA recognized, and the practices have different financial affiliations and primary type of insurance, which all have different financial structures. So each practice is carrying the cost burden in a different way. An interesting finding we discovered during the survey and interview process is that these practices all identify themselves as a patient-centered medical home using the framework set forth by the NCQA standards. And this finding is relevant in that by using the language and organizing their answers using these NCQA standards, it facilitated great data collection from our perspective on the research team. Also, as I alluded to earlier, due to their different financial characteristics and ability to respond to financial incentives, practices face significantly different financial burdens during their process of transformation to PCMH. And I'm going to talk about one example. The Chronic Care Initiative, or CCI, was a demonstration project by the Commonwealth of Pennsylvania that provided financial and educational incentives to practices in order to become a patient-centered medical home. And in our interviews, we found that 8 out of the 9 practices that previously participated in the CCI felt that they could not have successfully transferred to a patient-centered medical home without that lump sum financial incentive provided by the CCI. It was also interesting to find out that 5 out of the 11 practices allocated a significant portion of their lump sum incentive to new staff hires because they do not have the infrastructure in place to become a successful PCMH. These new staff hires include anywhere from providers, nurses, or highly trained medical assistants. Also, 3 out of the 11 practices felt that they faced significant financing concerns due to payer reimbursement. And this suggests that their practices were surviving from paycheck to paycheck. So this leads us to a key open question, which is whether compensation for this model of care exceeds the cost of implementing it from a practice perspective. After all their insight and data that we gained from the interviews, we try to conceptualize this balance between the costs and compensation from the practice perspective into a cost collection tool. This tool can be viewed similar to a tax document. It would allow practices to sit down with their financial statements over the previous few years and really self-quantify their costs of both transforming as well as sustaining the PCMH as a model of primary care. This tool has 5 different domains that are related to the PCMH implementation process, but I will just briefly touch on them today. The PCMH activity pillar is any cost that is directly or indirectly related to one of the NCQA accreditation standards, and it is a large majority of all the implementation costs. The second block is all the costs related to the NCQA application process, whether that be the time taken for applying itself or the fees associated with applying to NCQA. And then finally, the third block is composed of the costs attributed to changing the culture of the practice, which I think was one of the questions from the first presentation earlier today. So just going a little bit more in depth, looking at the cost taxonomy, the PCMH activity pillar includes those 6 NCQ activities, which are access and continuity, identify and manage patient populations, plan and manage care, provide self-care support, track and coordinate care, and lastly, measure and improve performance. The NCQA application process includes the cost of applying to NCQA, obtaining recognition, and maintaining that recognition. This time is uncompensated for most practices and not reimbursed. We also wanted some way to quantify the practice culture, which includes the cost and the change in philosophy, as well as both the provider and staff satisfaction and dissatisfaction. So the 4 economic categories describe the cost of inputs required for each clinical activity, which are all grounded in economic theory. The type of input includes both labor versus capital. The attribution of input includes direct versus indirect costs. The timing of input includes one-time versus ongoing costs, which allows us to really get at those transformation and sustaining the PCMH model. And the last category is the assessments of net costs. So before I connect these findings to larger policy implications, I want to place our project in perspective with some of its limitations. First off, there may be concerns of generalizability, given that most of our practices participated in the chronic care initiative and may not be similar to other practices that did not have that same opportunity. Likewise, the primary care market and financial pressures in southeastern Pennsylvania may be very different than the primary care market in central Illinois, for example. Also, I'd like to point out that our cost collection tool was created retrospectively, meaning that practices who already transformed into PCMH had to draw on their past experiences, costs, and financial statements to fill out this tool. And there may be concerns with how practices complete this tool, and we will likely learn much more about it as we set to pilot it out this week. So this all leads us to the most important question: what does our study mean and why does it matter? Given that there's no accurate estimate of how much it costs to implement the PCMH, as well as no consensus on what is the best way to finance the patient-centered medical home, our study raises the question, can the patient-centered medical home model be reasonably applied to all small practices? Is this a goal of policymakers? And if it's not, what type of small practices are the best candidates to become patient-centered medical homes? Also, since practices identify themselves using the NCQA standards, we feel that future tools and studies evaluating patient-centered medical homes should be based on these NCQA standards to facilitate data collection. Finally, we're hoping that small practices will be able to use our cost collection tool to quantify all the costs it took them to implement the patient-centered medical home model. This final cost will then provide policymakers and third-party payers a better idea on how to incentivize practices to become a patient-centered medical home and continue healthcare delivery system reform. So thank you for your time today.
Okay, so Colleen, you have various analysis ongoing and as the progress on the project is going forward. What were some of the challenges in conceiving this particular R03 analysis? Like, what type of information do you wish you had when you first started the grant the wisdom that you now have?
That's a great question. When some of my fellow colleagues went to present this work, some of the ideas that were sort of solidified were that this project in particular takes place in the Philadelphia area, which is a very competitive market compared to some other areas. And that sort of changes the context for things. Also, we gained a lot of insight as to this importance of the practice culture category for cost, because that's, I guess, a little bit less straightforward sometimes to gain that information, but also very valuable since this does require a lot of change for the practices. And then, of course, ongoing kind of prospective work would be very helpful for this study.
And so since NCQA and the certification is a popular certification, what were some of your strategies in reaching out and finding out what other cost estimates or experience that others have had beyond the Philadelphia area? What type of background information did you pursue?
That's a great question. Besides the interviews and surveys that we conducted with the small primary care practices, we also gained insight from a large primary care practice at Jefferson Family Medicine Associates, which is also in Philadelphia. I know a lot of my other colleagues did work more focused on sort of that broader question that you're getting at.
Okay.
But I don't have that answer with me today.
That's okay. I welcome others to write a question that we can pose to Colleen and ask that the other presenters come online now. For Robert and Elbert, who presented first, we had a very detailed question with respect to return on investment when one is estimating a particular diabetes-related intervention. So I guess you have a potential research partner who posed that question. Could you just provide to us kind of some of your reflections on, if you don't want to answer that particular very pointed question directly, you're welcome to, on return of investment with respect to diabetes interventions, or however you choose to answer that question would be welcomed.
Go ahead. Yeah. It's a good question. You know, the example that Robert gave of the managed care plan, where we had access to all the claims data for a select group of patients with diabetes, that's one way where you can empirically study basically the healthcare cost implications of intervention for patients with diabetes with real data. If you don't have that, there are alternatives to gathering data about. You can actually, in clinical trials, oftentimes we'll survey patients directly about their clinical resource utilization, health service utilization. That's one way to do it, and then using a price index can allow you to cost out the cost implications. The third way, which actually is related to another question, is we actually frequently use diabetes forecasting models or simulation models that allow you to forecast the rates of complications related to diabetes based on improvements in risk factor control or changes in medications in the short term. So that allows us to do these long-term cost effectiveness analyses of diabetes care improvement. So those are three methods with varying levels of ease and complexity.
And one more minor point to add with respect to the ROI component of the question is there's an important part of linking what Elbert just described in terms of the impact of cost of patient care back to that sort of research question one that we outlined around what's the cost of intervention, and obviously that's what gets you sort of your return on investment. And there's some good general resources and sort of calculator tools online to help people think through return on investment in healthcare that we use in working with practices sometimes. And I can pull that link up and email it to the organizers for sharing.
Oh, great. We would love to include that. And building on assessment of return on investment in the three different research questions that posed, could you elaborate a little bit further, because you found that increased costs related to higher level of PCMH was one of your main findings. Do you anticipate long-term return on investment that will balance that increased cost?
Yeah, I mean, that's the $100,000 question with respect to the medical home. I think it was Colleen who sort of summarized some of the current sort of state of the literature generally around the medical home. And, you know, I think at best we can say that's unknown still. There are definitely in the literature strong examples of PCMH programs that have reduced downstream inpatient admissions and ER admissions and reduced overall costs. Some of the prominent early examples in particular come from integrated delivery systems like Group Health Cooperative of Puget Sound. But there are also a number of studies that have not found sort of reduced downstream utilization that would be the financial benefits associated with the medical home. You know, most notably, one published just earlier this year in JAMA that didn't find associated benefits. So, you know, I guess no matter what the literature says across the board, I think the answer for folks who are actually on the ground in primary care practices is it's going to be a lot of it's going to be dependent on your context and sort of the specific of your situation and the way you're implementing the medical home. And lastly, you know, another point of context, if you're looking at sort of what business decisions are people making, you can point to the fact that a lot of payers are paying for medical home programs or providing financial incentives for primary care clinics to improve their medical home capabilities. So there's some evidence that, you know, for the folks where these types of investments, you know, hit their bottom line and hit them in the pocket, that there is the belief that there is an ROI there. But as far as a research perspective, it's definitely an open question.
Great, thank you very much. If we could go back to Dr. Stults and Dr. Tai-Seale, we have a question with respect to the use of SMAs in severe mental a population that suffers with mental illness. Do you have any particular examples or experience with that?
Yes, we do. We have the psychiatrists in our delivery organization. Several of them offer group visits or, you know, SMAs. A few of them are offering a lot of SMAs. Last time I heard from the psychiatrist who offers these, she is offering 10 a week now. So it's quite amazing. And Cheryl has interviewed that psychiatrist actually. I wonder if Cheryl wants to offer any, you know, additional information.
Sure. So some of these visits are recurring, so she holds up to 10 a week. So a few of them are with patients who do have kind of severe mental illnesses and come almost on a weekly or biweekly basis. And then there are other people that she has, like newly diagnosed, who can come and meet others who have also been recently diagnosed and answer any questions about medications or side effects or quality of life or other issues.
Great. I have a question about your SMA coordinator. How was that training for the SMA coordinator consistent or different from a practice facilitator?
So I'm not 100% familiar with what exactly a practice facilitator does, but in particular, her training was to learn about the shared medical appointments and to learn how she could work them into the workflow and to the other aspects from that. So maybe
it was a concentrated area with respect to the function that she would perform.
Exactly.
Okay, it sounds almost like she self-taught, Cheryl, is that?
Yes.
I don't think she went to
no, she didn't go to any.
Yeah, she read and she, you know, called people, learned from the folks on East Coast that are, you know, the organizations that are offering SMAs. but now she's becoming a resource for other clinics or other locations of the delivery organization that are also wanting to offer SMAs.
Great.
So knowledge is being shared.
Well, wonderful. A general question, for those of you who are looking at data from claims data, how do you deal with the uninsured patient population for whom care is not necessarily reimbursed? Was that a challenge for any of you?
That is claims data will basically not allow you to study those patients. There certainly is some cost. There is a cost to taking care of those patients. In our work with federally qualified health centers, they are indirectly compensated through basically federal grants. So there is a way to cover the cost of those patients, but it is a challenge to study directly what happens to the uninsured with the primary care intervention. So it's definitely an important but difficult population to study, and so that's why a Medicaid claims study, will not allow you to evaluate uninsured patients. Oh, there actually is one way to do it. We actually, and some data sets do actually have data on the uninsured. So, for example, we did work with the Medical Expenditure Panel Survey, and in that national kind of study where they do include the uninsured, you can get an indirect picture on their health service utilization. It's basically through surveys, but short of that, claims won't allow you to do that, but maybe national studies or surveys of the uninsured can help you do that.
And if you're looking at sort of, I presume a lot of folks on the call are interested in analyzing sort of their own sort of local primary care setting, and obviously national data sets can be tough for that. But Elbert earlier mentioned a couple of other ways that you can get at cost by assessing utilization, and so you can survey patients and ask them about their healthcare utilization over the past year, for example. And those are ways that within sort of the reach of the primary care organization patients you can get to, you might be able to ask about utilization and as is very common in these analyses, and model the cost component.
Yeah, so I think if you have clinic level data, then you will know, and if also if you know whether they're recognized by NCQA as patient-centered medical home, if you know when they were recognized, and then if you have access to their medical records, if it's electronic medical records, if they have billings information, for the uninsured, there would, the payer would just be, either self-pay or uninsured, rather than the, the commercial payers. So it's kind of a back way to try to get to at the uncompensated care part.
Thank you. And we can look at the MEPS has different guidance documents, since you brought that up, Dr. Huang, to see if there is a general instructions for people who use the MEPS database, how to have, for the surveys of the uninsured, how to estimate those costs. So that's we can follow up with that and see if we have something we can add to the collection of resources that you all have identified. So thank you very much for that.
Yeah, MEPS is managed by AHRQ, and they're very helpful, and it's an excellent resource.
Great, thank you. So with that, let's see if there was a general question with respect to the SMA about whether or not it was all your data was collected prospectively or retrospectively to self-report, but it, I believe it was a combination, was it not? If
yes,
you can clarify.
Yes, it's a combination. Most of it was retrospective. It's only some of the more recent, in terms of the cancer survivorship one. We talked with her when she was probably about 2/3 done with her planning stage before she started her first shared medical appointment, and then we followed up with her to find out then how much time she spent in that 1/3 of the time following up. So most of it was retrospective.
Yeah, but we are prospectively collecting data for one SMA that is in the process of being developed, right? You know, for patients with have undergone bariatric surgery, a psychiatrist is going to offer some SMAs for that patient population. So I just happened to have lunch with her, and I realized that there's not really like a clearinghouse of who's offering SMAs, who's planning to offer SMAs, or who have done that and now stopped. It's almost comical that sometimes people would come to us wanting to have a list of all the providers who are offering SMAs. So we learned about that SMA being planned. So we will be able to have prospective data. We will be able to talk to her before she offers it, and so there is this one exception.
Great, thank you. You've all given us great information and been very gracious and knowledgeable in your responses. I'm going to ask one last question for discussion among all the participants, but I do encourage everyone, and we'll go through this process about when you exit from here, if you want to get CME, you have to complete the evaluation of the presentation, but encourage everybody to complete it and give us suggestions of particular topics or presentations and other discussion points that we can have through the PBRN community. I think this is very helpful. But insight, as this one was, based on both Dr. Kronick's vision of where he wanted the agency to go and people's desired topics for us to discuss, was selected in response to, I guess, the grassroots and the leadership desires. But we want to hear from you. But the last topic is some of the challenge with respect to how do you measure cost when it's prevention activities, and where the prevention activities are not necessarily just in the healthcare setting, that can be realized through educating the patient on some of their personal behaviors. Are there any reflections? Well, we can start, we'll start on the West Coast and work east. Dr. Ming and Dr. Stults, do you have any reflections about challenges of prevention activities being measured?
I think that is, so we're not explicitly measuring that, even though, focusing on prevention, doing preventive care is an important component of patient-centered medical home. But we do have one other component in our cost study project is that we have institutionalized a sort of electronic medical record-driven automatic reminder system for preventive care. So we are in the process of collecting data. We, again, use the method that Cheryl had described, or it's really a modified sort of activity-based costing method, but it's more of a time-driven ABC, or sometimes people call it TDABC. So we basically go ask the developers of the auto-penned protocol for various preventive care reminders, the amount of time they spent, and who are involved. So it goes back down to understand the roles that were in the activity and how much time was spent by each role, and then we aggregate it up, and then using the national wage data to get to the cost. So I assume that if you're looking at community-based preventive care, you may want to talk to the community health agency and then find out from them, of the roles that are involved, and then, get the hours that each role, the staff basically spent on that. And then you will also want to consider, facility costs and supplies and all those things. So if they hold any community fairs, so that's kind of a general response.
Great, thank you.
Sure.
And then we can, Colleen, did you want to give us some reflections about measure of prevention activities?
Sure. I definitely agree with the presenter before me with everything that she said. Something unique to the context of Philadelphia that we included in our analysis was payments from the Chronic Care Initiative, which I discussed. And then also some of the practices really talked about some incentives or some money that they receive from different unique positions within the primary care setting, like a health educator or a pharmacist or a health behaviorist built into the practice. So those are some sort of unique ways that practices were able to have some of these upfront costs and help with sort of the prevention piece of everything. So yeah.
Well, I thank you all. I think this has been a very informative presentation, and there's more information we'll be able to share with our participants. And so, and I even encourage our presenters to let us know of other issues that they'd like us to follow up with in future national webinars. And so with that, Kristen, we can, so for those of you who are interested in obtaining CME credit, you need to complete the online evaluation that you'll be prompted to complete when you exit the webinar. And you have to contact that's the email address I gave at the very beginning, pbrn@APT Associates, which is ABTASSOC.com, to request a copy of our CME certificate of participation. And for all of you, if you have suggestions of other resources with respect to that, you can send it to the pbrn@APT, ABTASSOC.com, and we'll love to receive that from you. So I guess we're taking the month of August off because so many people are on holiday, but we'll start up with 2 national webinars in September. On September 10th, a discussion about IRB cooperation in different types of practice-based research networks with respect to hierarchical IRBs in particular. And then on September 30th, the PBRN Research Good Practices document, which has been worked on by many, many people in the PBRN community under the leadership of Victoria Neal. They will have a presentation, and they will also have that new document available for you all. And we'll have other topics. You can give us suggestions coming up. And I wish you all a wonderful end of summer, and thank you all for keeping connected with our PBRN community, and encourage other members of your PBRN to join us. And we look forward to serving you and chatting with you in the future. Thank you very much. This is a difficult topic, especially over the internet. It's difficult, and I thought our presenters were both engaging, informed, and kept us hoping for more as far as aptitude to pursue this type of research, which is always helpful. All right, take care and thank you. Bye-bye.
Thank you, Rebecca, and thanks to our presenters. And this concludes today's webinar.